Hi everyone, and very good evening to all of you. I hope that you all are doing fine and in the best of your health. This session is about the revision series of the NEET questions, and we'll try to make it as short as possible because you have important stuff to read also. I would encourage any doubts that you have, you may please come forward and ask me. At the same time, if you have some doubts in a question or regarding something else, you can also put in the live chat below. Okay. So starting with the session, we have around 20 questions of pathology here, and which I believe would be really helpful for you for the revision purpose. Now, without wasting any time, the first question, I'll move to that. Which type of defect is often seen in the hereditary non-polyposis colon cancer? So, basically, if you talk about the HNPCC, this one second. Purpose. Now, without wasting any time. Yeah. Okay. So, the first one you should understand is, can you please tell me the answer, guys? Now, for those who know it, please let me know the answer. What do you feel is the answer? C, exactly. Mismatch repair gene is the right answer. Now, see, when a question like this is often asked, it is expected from you to know some other defects also. So here it is a small list what you should know here. The DNA repair genes, they can be a hereditary non-polyposis cancer. HNPCC is the name. And HNPCC, as the name says, is due to the mismatch repair gene. Okay, it is due to the mismatch repair gene here. First thing. Secondly, what you must know is that xeroderma pigmentosa, okay, xeroderma pigmentosa, that is due to the nucleotide excision repair. Okay, xeroderma pigmentosa is due to the nucleotide excision repair. Now, often students get confused, sir, how to remember it. So, देखो, xeroderma pigmentosa, in that there is a X there. The first letter is X. That means, if you come back to the previous point, देखो, this nucleotide excision, this X is there, and hence it is the xeroderma. Okay, it's xeroderma pigmentosa. Okay. Now, this non-homologous end repair joining, this again is very important. And can you tell me which tumors actually are by the non-homologous end repair joining? The answer is it is Bloom syndrome, it is Fanconi's anemia, and is also due to the BRCA1 and BRCA2 mutated breast carcinoma. So basically, this is seen in Bloom syndrome. Okay, Bloom syndrome. It is often seen also in the Fanconi's anemia, Fanconi's anemia, and it is also seen in the BRCA1 and BRCA2 mutated breast carcinoma. All of these 1, 2, and 3, they show what is called as a non-homologous end joining repair. So please remember this; it will really be helpful for you. Okay, move to the next question. A 30-year-old male has presenting with fertility for 1 year. Now he has mild anemia, massive splenomegaly with TLC of 1,50,000 microliters. So this is also showing you neutrophils of 60%, eosinophil 4%, lymphocyte of 15%. So what is very striking here is a very high TLC. The first thing you should understand here is also seeing a myeloblast, myelocytes, metamyelocytes. I think this is quite a clear question. It is talking about a condition called as a chronic myeloid leukemia, CML. So what investigation should you do in CML? This is a very important question. So in a case of CML, the test that you should all be doing, most sensitive test, it is FISH and PCR. Okay, FISH and PCR. देखो, when we talk about the FISH and PCR, this, if you get both the option, FISH is the better answer compared to the polymerase chain reaction. Now, since this question, oh, 1 second, please. 1 second, please. Okay. Yeah, okay. Let's move forward. And what I was discussing with you was that because here the question is about the chronic mild leukemia, the better answer is FISH than PCR. Remember, if the question would have been the next step, then you could have done a lab scoring. But the confirmatory test is often done by the FISH and PCR. In lab, you must know that the user score of lab is from 0 to 400. If less than 25, it is called as low lab score. If more than 125, it is often referred to as a high lab score. So low lab score and a high lab score, you should also remember this. Now, often students get confused into, sir, when should you mark the option of immunophenotyping? Please remember, the question of immunophenotyping should be answered when you're answering about the acute leukemias. Okay. So remember, whenever the question is on acute leukemia or there is any blood-related cancer, not the tissue cancer, so blood cancer, then you can mark immunophenotyping, that is IPT. Now, often the role of IPT in a CML is very limited. You can use IPT in acute leukemia. You can also use this in a CLL. I hope you remember the CLL has 19 positive, 20 positive, 5 positive, and 23 positive. The moment you get 5 and 23 together in a case of tumor, you should always and always mark chronic lymphocytic leukemia, CLL. CLL. No, CML can occur in 30 years of age also, even though the more precise age of CML, which is quite higher, around 50 to 60 years of age. But surely CML can occur at 30 years of age also. It can occur at 30 years of age also. Please remember this, okay? It can surely occur at the age of 30 years also. Chalo, let's move forward, guys. Okay, look at this question. A patient who is having a webbed neck, okay, this patient is having webbed neck. What is the answer? Very good. The answer is Turner syndrome. Very good. The answer is Turner syndrome. So why is the answer Turner syndrome? Sorry. Okay. So the answer is Turner syndrome, mainly because it is having a webbed neck, it is shield-shaped chest, and the short stature. Now, if you remember the mnemonic of Turner syndrome, it is clowns. Okay. The clowns may the C is a coarctation of aorta. But remember, the most common cardiac anomaly in the Turner syndrome is not coarctation, it is bicuspid aortic valve. This is a very frequently asked question. It's a bicuspid aortic valve. L is lymphedema of hand and feet. O are the ovaries, which are streak ovaries, that means underdeveloped ovaries. W is the webbed neck. W is the webbed neck. N is the normal intelligence. That means they don't have ventral retardation, is normal intelligence. And S is the short stature. And along with that, you can also remember it is shield shaped chest. Shield shaped chest. Okay, shield shaped chest. So these are various things you should remember in a case of Turner syndrome. And how to remember the mnemonic of Down syndrome? So Down syndrome mnemonic is a problematic situation. Now please go through these mnemonics before the exam because this is really, really helpful while solving questions. Okay. If I ask about the main mutation here, I hope you all know this, but just for revision purpose, the basic mutation Down syndrome is trisomy 21. Turner syndrome is a monosomy of chromosome 45XO. Patau syndrome is just a trisomy of chromosome 13, and Edwin is trisomy of chromosome number 80. So next question. A research scholar, while studying cytoskeleton of a chronic alcoholic patient, has decreased lifespan, came across several strands of proteinous fibers wound together as a stable structure and distributable tensile forces across cell and tissue. The record indicates that the liver biopsy shows hepatocytes with reddish inclusion. Now, this is a very important question. So, to look for reddish inclusion in a case of alcoholic patient. So, what this reddish inclusion should have been? So, reddish inclusion should be, suppose there's a hepatocyte, there's a nucleus, and there's a red inclusion inside it. So, what will the red inclusion will be? This red inclusion. Yes, it will be mammary bodies. Very good. The mammary bodies are often seen in alcoholic steatohepatitis, and the best marker for this is, yes, it is intermediate filaments, and this can be stained by cytokeratin 8 and 18. Okay, they can be stained by cytokeratin 8 and 18 positivity. Okay, they can be stained by cytokeratin 8 positivity and 18 positivity. Now, just for revision purpose, what you must remember more in alcoholic liver disease, number one, you must try to remember the three stages. Stage number one is fatty liver. Stage two is the alcoholic steatohepatitis, and stage three is cirrhosis. The question that can be asked here is, number one, what are the findings of alcoholic steatohepatitis? Number one, it shows neutrophil infiltration in the portal tracts. Along with that, it shows ballooning degeneration and necrosis of the cells. And as the question mentions here, it can also show you the Mallory-Denk bodies. Mallory-Denk bodies. Mallory-Denk bodies. Okay. Next question. A patient with generalized fatigueness, tiredness, and primary clinical examination uneventful. Normal TLC and DLC was there, and no immature cells was seen. The superficial discrete lymph nodes are enlarged, and biopsy the entire lymph node is effaced, means destroyed, and indented nucleus, prominent nuclei, and there is atypical cells having 10 positive and BCL2 positivity. So before I move to this question, let's have a very quick revision as to what should you remember in different lymphomas. Dekho, whenever a question on lymphoma comes, few things will always help you, like BCL1 positivity, BCL2 positivity, and BCL6 positivity. First, you remember this thing. How to remember? BCL1 you remember as mantle zone lymphoma because mantle has single L, and hence L1 it is BCL1. Focal lymphoma has double L, and so it is BCL2 positivity. Okay, and BCL6 is often seen in diffuse large B-cell lymphoma. Then remember that BCL1 is on chromosome number 11. Okay, and BCL2 is on chromosome number 14, and BCL6 is on chromosome number 3. And therefore, you can also remember here that mantle zone lymphoma will have translocation of 11, 14. Yes. And focal lymphoma will have 14, sorry, this is 18, okay? This is 18. So 14, 18 translocation. And the DL B cell will have translocation of 3 with 14. These three are must and most to remember facts. Okay? Chalo, next question. The answer is what? Focal lymphoma. In Burkitt, remember, it should be c-MYC positivity and translocation of 8 with 14 is seen. So anytime you see chromosome 8, how to remember? Burkitt ka B. Remember from B it is C. So c-MYC ho gaya. And the B looks like number 8. So it is on chromosome number 8. Okay. All of them are non-Hodgkin lymphoma only. Now what will this mycosis fungoidosis show you? What will this mycosis fungoidosis show you? This will show you a Sézary cell. Very, very important. It will show you what? Sézary cell. And how does the cell look like? It looks like this, like a lobated cell, like this. Multiple lobations like this. It is called a Sézary cell, also called as the cell of mycosis fungoidosis. Mycosis fungoidosis. Okay. A patient with mediastinal mass was diagnosed with a red cell aplasia. So, what is the most probable cause of this aplasia? See, whenever there's a PRCA and the PRCA is seen with a mediastinal mass, this could be a straight away case of thymoma. Remember, thymoma as a paraneoplastic syndrome. Thymoma as a paraneoplastic syndrome shows often a mediastinal mass. Okay, and it shows a PRCA. About PRCA, you must also know that PRCA can be seen in any case of hemolytic anemia. Okay, and along with that, if a patient has which infection? Can you tell me which infection? Remember PRCA, so P, parvovirus B19, parvovirus B19, parvovirus B19. Okay, what other thing you should remember? Suppose a question is on bronchogenic carcinoma. So bronchogenic carcinoma may, it can be different type of carcinoma. Now I have a small revision. Please listen to me carefully. A bronchogenic carcinoma case, if it is a squamous cell carcinoma, okay, so then the marker are what? It is cytokeratin. Okay, it is cytokeratin. Okay, it can also be P53 and P63 is a more specific marker. For adenocarcinoma, the marker in a lung cancer is KRAS. It is EGFR1, but a very specific marker you should remember is thyroid transcription factor 1. TTF1 is a marker. And for any neuroendocrine tumors, for example, a small cell cancer, the marker are synaptophysin, chromogranin, and the neuron-specific analyase are the basic marker you can expect in the neuroendocrine tumors. Okay, this is done for bronchiolic carcinoma. About non-Hodgkin lymphoma, obviously it is like the B, T, and K, and different tumors will have the different markers. A squamous cell carcinoma, depending upon where it is, will have often a cytokeratin positivity, and if in lungs, will have P53 and a P63 positivity. Okay. Yes, P40 is also positive. Very good. P40 is also positive in the squamous cell carcinoma. Very perfectly answered. Okay. Next question. Pap smear with a hyperchromatic nuclei and pleomorphism with low maturation index. Please remember this, low maturation index. The cells are not maturing. The cells are not maturing. The cells are immature only. Having complete epithelial lining, but not involving the basal membrane. Every line has importance. What do you say is the answer? Tell me, fatafat. Tell me what is the answer. Fast, beta, fast. No, bronchogenic carcinoma can be any tumor which is occurring in the lungs. See, because it is often seen in bronchus, therefore you often say the bronchogenic carcinoma is bronchial carcinoma, which can be squamous cell carcinoma. Else, right, it can be anything. Okay. Yes, it is dysplasia. So dysplasia, remember, it can be, if you look at the classification, it can be mild dysplasia, moderate dysplasia, and can be severe dysplasia. Okay. Now, mild, moderate, severe, it always involves which layer? It involves lower 1/3, lower 2/3, and is full thickness. The full thickness is also called as carcinoma in situ. This was previously called as CIN1, CIN2, and CIN3. But nowadays in the Bethesda classification, the name has been given as LCIL for the first one, and these two are called as HCIL. LCIL for the LCIL. Please remember, it is often referred to as LCIL for the first one, and it is HCIL for the others. So it is mild, moderate, and severe. Mild, moderate, and severe. Yes, precancerous is this one. It's a precancerous lesion. Okay, hyperplasia is not a precancerous lesion, and the examples of hyperplasia, remember, pathological and physiological. Physiological examples of hyperplasia. They include the uterus and breast. Okay, and the pathological examples include the benign prostate hyperplasia and the endometrial hyperplasia. Okay, metaplasia can be, it can be squamous, it can be columnar. In the examples of the columnar metaplasia, the answer is only one, Barrett esophagus, and squamous cell carcinoma can occur in lungs. It can occur in the bile duct and the pancreatic duct. It can happen in the urinary bladder in case of schistosomiasis, and can also occur in the endocervix in the event of any infection. Complete revision of the all topics have been done here. Next, Chale. A 34-year-old woman has fever, migratory polyarthritis of lower large joints, and she has tachycardia. Murmur is pansystolic. It's a pansystolic murmur. So look at this biopsy here and tell me what do you think is the diagnosis. The question is so simple because it has given so many important history to you. So remember, it's definitely a case of rheumatic carditis, and rheumatic carditis has these all inflammatory cells here, and these all inflammatory cells here is called as a ash of body. Now, few questions you must remember for a NEET revision. Please listen to me again carefully. If the question is on acute carditis, in acute carditis, you often get a pancreatitis. Okay. Now, in the endocarditis, what you must remember, if the question is on endocarditis, the point that you must remember, just I'm moving this, I'm moving myself a bit, thoda sa hata deta hu, taki you can look at this slide also. So I'm just putting it here right now for some time. Dekho, basically, if the question is on endocardium, Then in a case of endocardium, it can be number one, vegetations in the mitral valve, and there can be the a thickened patch called as McCullum's patch. Okay, first revision. If the question is on myocarditis, so in myocardium it is ash of body. Okay, it's ash of body. And if the question is on pericardium, it is bread and butter, pericarditis. Okay. Now, if the question is on chronic carditis, then there is only one answer. It shows what? It shows the fish mouth appearance. It shows the fish mouth appearance. Simple. Okay, it shows the fish mouth appearance. Okay, it shows the fish mouth appearance in chronic rheumatic carditis. Okay. Also, if the question is, what are the findings of a rheumatic fever? So, rheumatic fever will have 5 major criteria and some minor criteria. Among the major, it is, bolo kya kya hai? It is carditis. It is syndrome scoria. Yes. What? It has migratory polyarthritis. It has erythema marginatum, that is rash. And it has what? It has the rheumatoid nodules. And in minor, there is fever, there is ASO levels. Okay, fever, ASO level is also there is a prolonged PR interval. Okay, so we need either at least more than one major, or you need either one major and two minor criteria to prove it is a case of rheumatic heart disease. Rheumatic heart disease. Chalo. Next question, fatafat, fatafat. Okay, we don't have time. Everyone has to study also. Okay. So next question. Poor prognostic marker for multiple myeloma is a simple question. It is beta 2 microglobulins. Okay. So in multiple myeloma, what all question can be asked in NEET? Especially in the NEET, they mostly focus on the prognostic marker and the CD marker. CD marker for multiple myeloma is CD38 and CD138. Okay, first question. Secondly, they ask you about the Benz-Jones proteinuria. Remember, Benz-Jones proteinuria is basically what? It is a light chain. Very good. Light chain matlab it can be kappa or can be lambda. Okay. Okay. Then must remember the benzoyl protein ki urea ke baad, you must also remember the serum electrophoresis. This question has been so frequently asked that if you do serum electrophoresis in case of multiple myeloma, what you get? The answer is a monoclonal protein. Okay, what you get is a monoclonal protein. So what is a monoclonal protein? Basically, if you take this serum of the patient and you do electrophoresis with a positive charge here, the lightest protein is albumin. This was an image-based question asked in last 2 years of NEET. And then comes the globulin alpha 1, alpha 2, beta, and the gamma globulin. These all are what? These all are globulins. And globulins are alpha 1, alpha 2, beta, and the gamma globulin. These all globulins will be there. What happens in multiple myeloma is there is a large peak here, as a big peak here, and this is called as a M protein. It is called as a M protein. Okay, it is called as a M protein. Okay, guys, so the PDF of this will be available after my session in my Telegram channel. You can download it from there for quick revision purpose also. So those who are a member of my Telegram group, please, you can download this PDF from my Telegram group also. No worries at all. Okay, everything will be available to you. Bas padhai karo. Only study and study, nothing else. Okay. Now remember, once a question was asked, suppose this is monoclonal protein, right? Now suppose the graph is something like this assay. Okay, it's a polyclonal graph. Okay, if it's a polyclonal graph, so in the polyclonal graph, what happens? One second, please. One second, please. This is going in and out. It has to always be activated. Chalo, it has come back. Move karte aage. So I was asking you, if the question is on polyclonal gammopathy, then what is your answer? In that case, the answer is the infection. So if the question is monoclonal, it is a multiple myeloma. But if the question is on polyclonal, then the answer becomes a infection. Okay, then the answer becomes infection. Very good. Chalo, next question. A 18-year-old male has a presentation of gum bleeding, okay, and easily fatality, fever for 2 months. An examination shows a non-specific finding of significant pallor, petechial rash all over the body, and hemoglobin and the hemoglobin here is 3. TLC 1500, plate count 1500, and the peripheral smear shows macrocytes, creatinine count is 0.5, and bone marrow shows fatty streaks. Absent macrocytes, no immature cells. I think there's too much history given to you. What is the answer? Yes, it should be idiopathic acquired aplastic anemia. Remember, aplastic anemia kya hota hai? It is a simple case of pancytopenia and along with that a hypocellular bone marrow. Hypocellular bone marrow means the bone marrow percentage celerity should be less than 25%. Simple. Less than 25%. Okay. Secondly, suppose the question is PNH. Sorry. So in a PNH, there can again be pancytopenia. But remember, in a PNH with a pancytopenia, there is not hypocellular marrow. There is a hypercellular marrow in a case of paroxysmal nocturnal hemoglobinuria. If it's a myelodysplastic syndrome, this would be again a case of pancytopenia, but along with that, there is cellular bone marrow. So because the option is giving you a cellular bone marrow, therefore, sorry, therefore, you must all remember that the question answer cannot be the option C or D. But about the disseminated TB involving bone marrow, this can again show you pancytopenia, and this will show you almost a moderately cellular bone marrow. That means the moment you get in a question a hypocellular bone marrow, always think about aplastic anemia only. Always think about aplastic anemia mainly. ठीक है? चलो आगे बढ़े. No time wastage. Okay. All transretinoic acid used in the treatment of the what? Yes, the answer is APML. Remember, in APML, the basic translocation is the 15 and 17. On 15, there's a PML gene, sorry, PML. On 17, there's a RARA gene. So what happens? The drug is called as ATRA, all trans-retinoic acid ATRA. This will break this translocation and hence is often used in treatment of what? In the treatment of APML, PML, RARA. Now, what drug you use for B? Okay, SEPA. Where do you get SEPA? SEPA is often seen in Bolo. SEPA is often seen in this one. It's a good prognostic marker for AML. It's often a good prognostic marker for AML. AML. Okay. So answer clearly is PML RARA mutation. PML RARA mutation. One more thing often students ask me, sir, what is the difference of treatment of ALL and AML? First of all, both of them are given induction phase. Okay? And after induction, in ALL we give maintenance therapy, which often goes for around 2.5 years. Here also we give induction therapy, but after induction therapy, which induces remission, we often give a not maintenance therapy, but what we give is a post-remission therapy. Okay, it is called as post-remission therapy. So remember, induction induces remission, and after induction, we give a post-remission therapy in case of AML. The overall duration of ALL treatment is 2 to 2.5 years. Okay, but AML has a lesser duration. It often lasts around 2 to 2.5 months. A big difference between both of them. Okay, next question. This is a straightaway question. Tell me the answer. Fatafat. No time wastage. Okay. A 25-year-old man has routine physical examination. The patient is tall. Okay, is tall, and examination is found to have an early diastolic murmur. What is the diagnosis? Yes, it's Marfan syndrome. Yes, Marfan syndrome is what? It is autosomal dominant. It's autosomal dominant. So, देखो Marfan syndrome में ना, try to remember the mnemonic Marfan's only. In Marfan syndrome, what are the findings? I hope that you all have seen this mnemonics. So I've given you all the mnemonics. Okay, do not forget the mnemonics. देखो कैसे. The finding of Marfan's is Marfan's, and how to remember? Simple. Mitral valve prolapse. Okay, mitral valve prolapse. Aortic aneurysm is A. Mitral valve prolapse. Aortic aneurysm. Retinal detachment is R. Thyroid deficiency. Remember, the main gene is FBN gene, which causes increase in TGF beta, and hence there's a defect there. Okay, adaptodactyly, negative nitrobocyte test, supero temporal subluxation of lens, and stutter changes. I am telling you guys, This is a mnemonic in my Telegram group. All of you, please go through this mnemonic. Klinefelter ka mnemonic hai, Turner syndrome mnemonic hai. There is also a mnemonic for this Down syndrome. And apart from that, the mnemonic I given to you is also for the autosomal dominant. Pakka question aata hai isse. Autosomal dominant mnemonic, autosomal recessive mnemonic. There's the X-linked recessive mnemonic and the X-linked dominant mnemonic. All of them are very frequently asked in the NEET exam. You will surely get a question from this. So don't miss this question. Okay. Chalo. Moving ahead, the following plays a major role in initiation of thrombus formation. So thrombus formation creates what? It is Werkhaus triad. Okay. What is Werkhaus triad? Werkhaus triad is three things. 1, 2, and 3. It is endothelial injury. Remember, this is the first response. Okay. Secondly, it is any abnormal blood flow. Okay. Now remember, abnormal blood flow can indicate stasis also, and can also be turbulence, can be anything. Okay. And the third is the hypercoagulability of blood. It is the Werkhaus triad. Three things, and the first is therefore the endothelial injury. A few things, almost you must also remember that what is the change and how does the sequence of the primary hemostatic plug occurs. The first thing is endothelial injury. This injury causes transient vasoconstriction. This transient vasoconstriction initiates the event of turbulence. Okay, turbulence. Then after turbulence, what happens? There is the platelet adhesion. Yes, adhesion के बाद release of granules. Which granules? The delta granules. Delta are the platelet agonists, and this causes platelet aggregation. So please remember, it starts with endothelial injury, then initiates a transient vasoconstriction, turbulence, platelet adhesion, granule release, and the platelet aggregation. Now, one more question is, what are the examples of the delta granules? Delta granules, remember by the mnemonic dense. Delta is dense. DENSNE. मतलब adenosine diphosphate. S is serotonin, E is epinephrine, and along with that there's also calcium. These all belong to the dense granules. Okay, dense granules. Remember this. Okay, फटाफट. Okay, sir, what are in the alpha granules? Anyone? Alpha में क्या होता है? The alpha granules has what? They have all the factors. कैसे याद करोगे? Factor 1, factor 5, factor 8, right? What other factors? Platelet factor 4. Which other factor? Sir, PDGF. Very good. So all the factors are in the alpha granules. But when you move to the delta granules, dense is the mnemonic. DENSNE. Dense. Simple. DENSNE. Simple. Okay. आगे बढ़े. A 33-year-old man has a 5-week history of calf pain and swelling for low-grade fever. He has a serum creatinine level of CK are elevated. Muscle biopsy shows numerous eosinophils. The moment you see eosinophils, which interleukin? Yes, it is IL-4. IL-4. Often this question can be solved by just having a small revision of the Th1, Th2 and Th17 cells. From the last 2-3 years, I've noticed the question on Th1, Th2, Th17 cytokine is very frequently asked nowadays. So let's have a very small revision. फटाफट करते हैं revision. देखो, APC presenting a chronic antigen to a TH cell patient, and 12 and gamma will activate what? Macrophages. Okay. Next question, sir. If the question is TH2, then remember the APC presenting a allergen or a parasite to a TH2 cells. Okay. In this case, the APC releasing IL-4 will activate TH2. The TH2 will now release IL-4, IL-5, IL-13. IL-4 will activate B cell to release IgE. IL-5 will increase eosinophil as was a question asked in this question. And IL-13 will increase the mucin production. So do I need to remember all cytokines? Yes, beta, you have to remember every cytokine asked here. Okay. Suppose this question is APC. Suppose the question is APC. If the question is APC releasing or activating, sorry. If the question is APC activating the bacteria or a fungus, then it is Th17 cells. Th17 cell will then release IL-17 and 22. And this will activate what? Neutrophils and monocytes. So please don't forget the role of Th1, Th2 and Th17 cells. Okay, chalo, next question. A 45-year-old person who is a chronic smoker came to the clinic with complaints of cough. The biopsy has been shown below. Now this is a chronic smoker who has cough production. The picture is a biopsy with a description here. What is it? It's a case of metaplasia. Actually, this question is not a very well framed question. The question should be actually this should be a answer of metaplasia of respiratory system showing squamous metaplasia, but the image given here is of Barrett esophagus. Okay, so this is a squamous epithelium, and these are all the columnar epithelium. The image and this is not matching, so don't worry about this. This question is on the respiratory epithelial metaplasia, which is a squamous metaplasia, but the image is of Barrett esophagus. Okay, they're not matching, but yes, this is the question. I cannot change it right now, but yes, the answer is metaplasia only. Okay. Anyway, remember the dysplasia is the abnormal growth, and if the question is what are the finding of dysplasia, dysplasia cells often show hyperchromatism, pleomorphism, high NC ratio. They also show loss of polarity. Okay, and remember dysplasia can be mild, moderate, severe. Once it invades from dysplasia, it is now converting to a carcinoma case. Okay, CIN3 is just like a severe dysplasia. Next question. A 5-year-old boy child has a clinic with a history of recurrent infection. He has rashes and he has low platelet count. Three things you got. What is this? It's a case of Viscott Aldrich syndrome. Okay. So what is this? It's a case in which there's a VASP gene defect. It's a extinct recessive defect, and which VASP is TEI. As the name says, TEI matlab thrombocytopenia. There is eczema and there is infections, and there is infection. Three things often happen in the Viscott-Aldrich syndrome. The basic problem with Viscott-Aldrich syndrome is that the B cells, they don't respond to the polysaccharide antigens. Please remember, the B cells don't respond to the polysaccharide antigens. Okay, Job syndrome में क्या होता है? There's increased amount of IgE. There's also increased amount of Staph aureus infection, causing a pyogenic abscess is seen in the Job syndrome. In HSP, what do you find? You find palpable purpura, and you find IgA deposition in vessels. Okay, IgA deposition in vessels is the hallmark finding of Henoch Schwann purpura. In Bruton's agammaglobulinemia, what happens? It's a Bruton's extinct agammaglobulinemia in where the gene is a BTK gene defect, and because of the BTK gene defect, what happens? The B cells are not able to get produced. Actually, the pre-B cells don't become a B cells, the pro-B cell do not become a pre-B cell, and the pre-B cell do not become a B lymphocytes. So actually, there's complete absence of B lymphocyte in Bruton's extinct agammaglobulinemia. It is an extinct recessive response in which a pro-B cell doesn't become a pre-B cell, a pre-B cell doesn't become a B lymphocyte. So ultimately, there's deficiency of a B lymphocyte. Please remember, if a B lymphocyte is there but is not becoming a plasma cell, this defect is called as CVID. Okay, common variable immunodeficiency. Common variable immunodeficiency is a condition which is called as CVID, in which a B cell don't become a plasma cell. Okay. Okay. The following is a correct statement related to Huntington's chorea. Trinucleotide repeats. Sorry, is a trinucleotide repeats? Yes, that's true. Okay. CUG? No, it is CAG. Now, can you tell me which amino acid comes from this CAG? Fatafat, fast, fast. Which amino acid comes from here? It's not a loss, it's a gain of mutation. And which chromosome, beta? Answer me two questions. Which amino acid and which chromosome? Fatafat. Fast. Only two questions are left. Yes, it is glutamine. Perfectly answered. Glutamine. And chromosome number is 4. Chromosome number is 4. Okay? Two questions and two answers. The main, it is polyglutamine. So multiple polyglutamine is there because of CAG, and it is on the chromosome number 4, not 17. Chromosome number 4 is often involved in the Huntington's chorea. So what are the other trinucleotide repeats? It can be seen in the coding region, and in the non-coding region. Coding and the non-coding region. In the coding region, it is Huntington disease, CAG. How to remember? I hope you all remember. CAG is a cage. Cage. Animal in a cage. And non-coding में F and M. F and M. ठीक है? F क्या बच्चे? Fragile X syndrome. Okay. Next F is Friedreich's ataxia. And what is M? Myotonia dystrophica. Dystrophica. ठीक है? In a Fragile X syndrome, what is there? Remember, it is CGG. Ataxia is a gait problem, GAIT gait problem, so GAA. And dystrophica is CTG, T for T. Simple है ना? CTG, T for T, gait, so GAA, and Fragile X is CGG. And in Huntington, it is CAG repeat, CATG repeat. ठीक है? Okay. A 10-year-old boy has a complaints of fatigueness and abdominal pain after playing football. Football खेल रहा है. Then he has complaints of painful swelling in the digits in the past. And there's a small spleen. I think plenty of things have been asked and given to you. It is very good. It is fragile X inheritance क्या होता है? Okay, very good question. A fragile X inheritance is mostly X-linked recessive and X-linked dominant. If you have both in the option, a better answer is X-linked dominant more than X-linked recessive. Okay, but both of them are there. Both of them are there. Okay. Chalo, next question. Yes, it is sickle cell anemia. It is HBS. And I think, and you know everything about HBS. HBS mein what you must remember is the treatment of HBS sickle cell anemia should be IV fluids, oxygen therapy, and you must also give hydroxyurea to increase HbF. But the best treatment is, yes, it is, bolo, it is hematopoietic stem cell transplantation. Remember, the most common symptom is painful dactylitis, and then there is infection occurring in the bone and in the lungs can be there. So osteomyelitis caused by Salmonella typhi, and it is pneumococcal infection in lungs. Apart from that, these are all reversible findings. Apart from that, there can be ischemia in the brain causing stroke. There can be kidney causing papillary necrosis, and ultimately it can cause the ischemia of the spleen, which can lead to, yes, autosplenectomy. Remember, the autosplenectomy is often initially shows congestion and later on shows the infarction. In congestion, there's a body called as gamma Gandhi body seen. Later on, when there's irreversible sickling, there is now there's event of formation of hemolytic anemia. Okay, hemolytic anemia will be there. So all of them should be come to your mind. What is the diagnosis? You use, yes, sickling test. And what is the substance in sickling test? It is sodium metabisulfite. Sodium metabisulfite is used in the sickling test. And what is the diagnosis? You do HPLC. In HPLC, HbA will be low and HbS will be high. And the best treatment for the best diagnosis for sickle cell anemia is mutation analysis. Please remember, in any inherited disease, the moment you get a option of genetic disorders or genetic analysis, always go with that. And in genetic analysis, the best thing being done nowadays is gene sequencing. Sequencing is the best way, and therefore, if the question is on thalassemia, sequencing, sickle cell, sequencing, HS, sequencing, GSPD, sequencing. Mutation is the best way to diagnose any of these inherited disorders. Okay. Next question and the last question. Okay, fatafat. A 25-year-old woman, male, has a 2 centimeter old nodule and thyroid tumor is done. What are you seeing? You're seeing all of them are what? Papilla. And more importantly, look at the cell. The cell is not like this. The cell is like this. So what is it? It is orphan ani nuclei. Orphan ani nuclei, also called as a pseudo inclusion. It is seen in papillary carcinoma of thyroid. Remember, the papillary carcinoma of thyroid occurs in young age. It has a solitary nodule, and क्या याद रखना है? It is due to radiation therapy. If the question is on follicular carcinoma, the follicular carcinoma often occurs in those patients and in those areas where there is thyroid deficiency, iodine deficiency. Okay, so iodine deficiency में follicular carcinoma. In radiation exposure, papillary carcinoma. And when to mark medullary carcinoma? So medullary carcinoma is a neuroendocrine tumor, and hence will show you what? The neurosecretory granules. Which mutation there? Red gene. Yes, red gene, MEN2A and MEN2B in the medullary thyroid carcinoma. Okay, what else you must remember? Which tumor cannot be differentiated by FNAC only? It is follicular adenoma versus follicular carcinoma. Why? You need to prove for the invasion and you want to prove for the mets in the vessels. What else you must know in thyroid? You must know about the Graves disease and you must know about the Hashimoto thyroiditis. In Graves disease, the main gene involved is PTPN22. PTPN22 is the main gene involved in Graves disease. It's a type 2 hyper cell reaction, and the antibodies in Graves disease is thyroid stimulating immunoglobulin TSI, thyroid stimulating immunoglobulin TSI. And for a Hashimoto, remember the basic problem is it's a type 4 as well as type 2 hypercell reaction. Which antibody in Hashimoto? Anti-TPO antibody, thyroid peroxidase antibody, TPO antibody in the case of kisme Hashimoto thyroiditis has TPO antibody. That is how you also follow it up. What else you must know? Hashimoto has three main things. Number one, immense amount of lymphocytic proliferation, making germinal centers, and the hallmark finding of Hashimoto thyroiditis is hallmark finding. Yes, it is Hurthal cell change, also called as oncocytic change. It's a hallmark finding of Hashimoto thyroiditis. Hashimoto thyroiditis. Okay? So that is the end of today's discussion. Please ensure that you read well, revise well. Everything is now in your hands. Do not waste any time. Do not even feel even a bit demotivated. You will surely do it. Keep your motivation high, revise what you can, and do not waste any time. Everyone is going through the same phase. It is only the person who gets a right momentum in the last 7 days will be the winner. So do not waste the momentum. Please study well. Please study hard. Revise what you want to, but only you can do this if you make a well plan for that. So please make a plan of what you want to revise. Just don't revise anything you want to. Please have a plan for it. And the planning should be notes, previous year questions, bus. Nothing new should be done right now. Notes and the previous questions, nothing new should be read and done right now. Guys, wishing you all the best. Take care, study well. I'm with you. Let me know what you else want from us. We'll surely bring it for you. Please have the confidence. Result is out for NLCT. Don't worry about it. There are different exams. You'll have different results. I'm telling you, different exam will surely have different results. Just keep your momentum going on and on. Okay, take care, wishing you all the best, and let me know. Just put a like into this video if you really liked it. एक बार like डाल दो, and we'll then meet in the next session upcoming in the upcoming days. ठीक है? So about this PDF of the session will be, this PDF will be available in my Telegram group just after the finishing of this session. Okay, goodbye, take care, God bless you all.